እሺ ዛሬ የምናየው ስለ ማላሪያ ነው። So as introductory part, malaria is parasitic infection which are caused by plasmodium species which are known to have affects the human. The commonest cause of malaria in our country settings are Plasmodium falciparum and Plasmodium vivax. Plasmodium falciparum causes virtually all severe form of malaria. So malaria is a major health problem in Ethiopia and has been consistently reported as one of the leading cause of our country's patient morbidity and mortality. So about 52 million people, or around 68% of our people, live in malaria risk area in Ethiopia, primarily at altitude below 2,000 meters. When we look about clinical malaria, there are non-specific symptoms, physical findings, and laboratory diagnosis. So based on clinical malaria, there are non-specific symptoms: lack of sense of well-being, fever spikes, chill, rigor, occur at regular or irregular interval, headache, fatigue, abdominal discomfort, muscle ache. These are non-specific symptoms of malaria clinically. Based on physical finding, there is fever, mild anemia, common among young children living in area with stable transmission, and palpable spleen in some cases, that means splenomegaly. Based on laboratory diagnosis, there is microscopic diagnosis of malaria. It is a gold standard and initial diagnosis of level of parasitemia, and it indicates evolution of the rate of clearance of parasitemia. RDTs are also laboratory diagnosis to identify malaria species. Flowcharts for the diagnosis of malaria. So when we suspect clinical malaria case, see as box 1. So box 1. So when we suspect clinical malaria in scenario with the patient with fever or history of fever in the last 48 hours and lives in malaria endemic area or has history of travel within past 30 days to malaria endemic area, so we can see we can suspect malaria clinically, and we identify by microscopy. So our microscopy results are negatives. Look for other cause of fevers, and our microscope result is positive. We can check positive P falciparum or mixed P falciparum and P vivax. When it is severe form of malaria, treat accordingly or refer, and when it is non-complicated malaria, treat with AL or artemether lumefantrine 20 mg by 120 mg or by quartum. When the microscope result is positive for P vivax, treat with chloroquine. So classification of malaria. Malaria is classified based on complication. So uncomplicated malaria and a complicated or severe form of malaria. So uncomplicated malaria is defined as symptomatic malaria without sign of severity or no evidence of clinical or no evidence of laboratory of vital organ dysfunction. It is only symptomatic. This is called uncomplicated malaria. When we say the malaria is complicated or severe form, it includes presence of one or more sign and symptom of severe illness and or demonstrate sexual P falciparum parasitemia in the peripheral blood sample. Classification of malaria based on sign and manifestation. So it may be expressed in arousable coma or cerebral malaria, failure to localize or respond appropriately to noxious stimuli, coma persisting for greater than 30 minutes after generalized convulsion. The patient may come with acidemia or acidosis, that means arterial pH of less than 7.25 or plasma HCO2 less than 15 millimole per liter. Severe chromic normocytic anemia, hematocrit of less than 50% or hemoglobin of less than 5 gram per deciliter with parasitemia less than 10,000 per microliter. This is severe chromic normocytic anemia. Renal failure, Serum creatinine of greater than 3 mg per deciliter. The urine output of the 24-hour is less than 400 ml in adults, or less than 0.3 ml per kg per hour in children. So no improvement with rehydration. This is called renal failure as a result of malaria. Pulmonary edema or adult respiratory distress syndrome. So no cardiogenic pulmonary edema, often aggravated by overhydration. Hypoglycemia. The patient may come with hypoglycemia. That means the plasma glucose level is less than 40 milligram per deciliter. So classification of malaria and manifestation is also continued. The patient may come with hypotension or shock. Systolic blood pressure is less than 50 millimeter of mercury in children 1 up to 5 years, or less than 80 millimeter of mercury in adults. Core or skin temperature difference of greater than 10 degrees Celsius, and capillary refill greater than 2 seconds. Bleeding or disseminated intravascular coagulation. It's significant bleeding and hemorrhage from the gum, nose, GIT, or evidence of drug DIC. Convulsion, more than 2 generalized seizure in 24 hours. Hemoglobinuria, macroscopic black, brown, or red urine, not associated with the effect of oxidant drug and RBC enzyme deficit, such as G6PD deficiency. Extreme weakness, prostration, inability to sit unaided. Hyperparasitemia, parasitemia level of greater than 5% in non-immune patient. Jaundiced, the patient may be jaundiced. That means serum bilirubin level of greater than 3 mg per deciliter if combined with parasite density of 1000 per microliter, or other evidence of vital organ dysfunction. When we look about management, first, when we treat management, the desired outcome is these things. The first thing is to eradicate the infection within 48 to 72 hours. So within 2 to 3 days, the infection pattern should be eradicated. The second desired outcome when we treat malaria is avoiding complications such as hypoglycemia, pulmonary edema, and renal failure that are responsible for increased mortality in malaria. Treatment of uncomplicated malaria. If the species P. falciparum positive, the first line is artemether plus lumefantrine 20 by 120 milligram plus single dose of primocin. So 6-dose regimen of P. falciparum for over 3-day period is highly recommended. So AL is given for patient based on patient's weight and the patient's age. So when the patient's age is 4 up to 2 years and the patient's weight is within 5 up to 14 kg weight, it takes 1 tab POBID for 3 days. If patient's weight range is 15 up to 24 kg and its year is 3 up to 7 years, to tab POBID for 3 days. Our patient's kg is 25 up to 34 kg and the patient's year is 8 up to 10 years. The patient take 3 tab POBID for 3 days, and the patient's kg is more than 35 kg and its year is greater than 10 years, 4 tab POBID for 3 days of AL or quartam if the malaria is uncomplicated and P. falciparum species. As alternative, quinine hydrochloride 600 mg POTID for 7 days is highly recommended as alternative for P. falciparum positive or uncomplicated malaria. Treatment of uncomplicated malaria if the species is P. vivax. First line chloroquine 150 mg base tab, or if it's on salt form, chloroquine 250 mg phosphate salt form on divided base for 3 days. That means dose of 10 mg base per kg pure immediately at day 1, at day 2 10 mg base per kg at 24 hours or day 2, and 5 mg base per kg pure at 48 hours or day 3. So in 3 For 3-day divided form, we can give chloroquine for PVivax plus primaquine 0.25 milligram per kg for 14 days for PVivax malaria if our patient's malaria is uncomplicated. So the main role of adding primaquine is to eradicate liver phase in PVivax and P. ovule infection. The mixed infection, artemether plus lumefantrine 20 by 120 mg L plus primaquine 0.5 mg per kg for 14 days highly recommended. Treatment of severe malaria. So IV or IM artesunate is the preferred form to treat malaria as a severe form. IM artemether is also available. IV quinine infusion is also available, but the most important medication for treatment of severe malaria is IV or IM artesunate. As alternative, IM artemether is highly recommended. Treatment of severe malaria. Artesunate dosing 2.4 mg per kg body weight IV or IM given on admission at T0, then at T12 hours and at T24 hours. Then it can be continued daily for up to 5 days based on the patient status. The preparation for artesunate it contains 60 mg powder within 7 ml glass vial. So first reconstitute by mixing 1 ml glass ampoule of 5% sodium bicarbonate solution, then shaken to up to 3 minutes for better dissolution. For IV form, add 5 ml of 5% glucose or NS, then infuse slowly IV 3 up to 4 ml per minute IV. For IM, add 2 ml of 5% glucose or NS to be reconstituted 7 ml vial to make 3 ml of artesunate 20 mg per ml for IM injection. Malaria in pregnant women. If our patient is pregnant woman, we can consider treatment as alternative. So quartam is not recommended for P. falciparum speech, especially in the first trimester of pregnancy. For our patient is on the first trimester of pregnancy. Oral quinine administered at 10 mg per kg or up to 600 mg 3 times daily for 7 days. And the P. falciparum or mixed infection during second or third trimester treated with AL. P5X infection in all trimester should be treated with chloroquine 150 mg base tab or 250 mg chloroquine phosphate salt in 3 divided dose. So chloroquine is not contraindicated for pregnancy and it should be treated for all form of species. When it's in the severe form of infection, drug of choice is artesunate infusion. As alternative, quinine infusion or artemether is highly recommended. Site of action for anti-malarial drugs. So tetracycline, tissue schizontoside, primaquine, pyrimethamine, progranil, blood schizontosides ላይ አክት የሚያደርጉት ክሎሮኪን፣ ሚፍሎኪን፣ ኪዩኒን፣ ቴትራሳይክሊን፣ ጋሜቶሳይድ ፕሪማኩዊን፣ ስፖርኖንቶሳይድ ፕሪማኩዊን። Antimalarial drugs mechanism of action. Blood schizontoside drugs are suppressive or clinical attack parasite in RBC, preventing or ending clinical attack. Gametocidal destroy sexual form in humans, decrease transmission. Hypnosidal kill dormant hypnocyte in liver. Sporontocidal inhibit development of oocyte in mosquito, decrease transmission. Antimalarial chemoprophylaxis. So consider immune status, intensity and duration of exposure, parasite drug resistance, resource for diagnosis and treatment, drugs for prophylaxis of malaria. Atovaquone proguanil 250 by 100 mg once daily. Start 1 day earlier, continue throughout the stay and for 7 days after returning. Chloroquine or mefloquine if it is resistant. Doxycycline 100 mg every day. So chloroquine or mefloquine if it is resistant, start doxycycline 2 days before and continue daily during travel. As a personal protection to protect the person from preventing infection of malaria, you can use protective clothing, inspect repellent, household insecticide product, window and door screen. Bed nets are highly recommended to use to prevent malaria. This is today's topic. Thank you.